Hello friends, today I am going to discuss with you about chickenpox in pregnancy, green top guideline number 13 summary. Executive summary of recommendations. Varicella prevention. Can the non-immune woman be immunized prior to pregnancy or postnatally? Varicella vaccination pre-pregnancy or postpartum is an option that should be considered for women who are found to be seronegative for varicella zoster virus immunoglobulin G. While universal serological antenatal testing is not recommended in the UK, seronegative women identified in pregnancy could be offered postpartum immunization. Women who are vaccinated postpartum can be reassured that it is safe to breastfeed. Can varicella be prevented in the pregnant woman at her initial antenatal visit? Women booking for antenatal care should be asked about previous chickenpox, shingles infection. Women who have not had chickenpox or are known to be seronegative for chickenpox should be advised to avoid contact with chickenpox and shingles during pregnancy and to inform healthcare workers of a potential exposure without delay. Can varicella infection be prevented in the pregnant woman who gives a history of contact with chickenpox or shingles? When contact occurs with chickenpox or shingles, a careful history must be taken to confirm the significance of the contact and the susceptibility of the patient. Pregnant women with an uncertain or no previous history of chickenpox or who come from tropical or subtropical countries who have been exposed to infection should have a blood test to determine varicella zoster virus immunity or non-immunity. If the pregnant woman is not immune to varicella zoster virus and she has had a significant exposure, she should be offered varicella zoster immunoglobulin as soon as possible. Varicella zoster immunoglobulin is effective when given up to 10 days after contact. In the case of continuous exposures, this is defined as 10 days from the appearance of the rash in the index case. Non-immune pregnant women who have been exposed to chickenpox should be managed as potentially infectious from 8 to 28 days after exposure if they receive varicella zoster immunoglobulin, and from 8 to 21 days after exposure if they do not receive varicella zoster immunoglobulin. When supplies are limited, issues to pregnant women may be restricted and clinicians are advised to establish the availability of varicella zoster immunoglobulin before offering it to a pregnant woman. Women who have had exposure to chickenpox or shingles, regardless of whether or not they have received varicella zoster immunoglobulin, should be asked to notify their doctor or midwife earlier if a rash develops. A pregnant woman who develops a chickenpox rash should be isolated from other pregnant women when she attends a general practice surgery or a hospital for assessment. A second dose of varicella zoster immunoglobulin may be required if a further exposure is reported and 3 weeks have elapsed since the last dose. The pregnant woman who develops chickenpox. What are the maternal risks of varicella in pregnancy? Clinicians should be aware of the increased morbidity associated with varicella infection in adults, including pneumonia, hepatitis, and encephalitis. Rarely, it may result in death. How should the pregnant woman who develops chickenpox be cared for? Pregnant women who develop a chickenpox rash should immediately contact their general practitioner. Women should avoid contact with potentially susceptible individuals, example, other pregnant women and neonates, until the lesions have crusted over. This is usually about 5 days after the onset of the rash. Symptomatic treatment and hygiene is advised to prevent secondary bacterial infection of the lesions. Oral acyclovir should be prescribed for pregnant women with chickenpox if they present within 24 hours of the onset of the rash and if they are 20 weeks of gestation or beyond. Use of acyclovir before 20 weeks should also be considered. Acyclovir is not licensed for use in pregnancy, and the risks and benefits of its use should be discussed with the woman. Intravenous acyclovir should be given to all pregnant women with severe chickenpox. Varicella zoster immunoglobulin has no therapeutic benefit once chickenpox has developed and should therefore not be used in pregnant women who have developed a chickenpox rash. Should women be referred to hospital? The pregnant woman with chickenpox should be asked to contact their doctor immediately if she develops respiratory symptoms or any other deterioration in their condition. Women who develop the symptoms or signs of severe chickenpox should be referred immediately to hospital. A hospital assessment should be considered in a woman at risk of severe or complicated chickenpox even in the absence of concerning symptoms or signs. This assessment needs to take place in an area where she will not come into contact with other pregnant women. Appropriate treatment should be decided in consultation with a multidisciplinary team. Includes an obstetrician or fetal medicine specialist, a virologist, and a neonatologist. Women hospitalized with varicella should be nursed in isolation from babies, potentially susceptible pregnant women, or non-immune staff. When and how should the woman with chickenpox be delivered? The timing and mode of delivery of the pregnant woman with chickenpox must be individualized. When epidural or spinal anesthesia is undertaken in women with chickenpox, a site free of cutaneous lesions should be chosen for needle placement. Risks of maternal varicella infection to the fetus or baby. What are the risks to the fetus of varicella infection in pregnancy, and can they be prevented or ameliorated? Women should be advised that the risk of spontaneous miscarriage does not appear to be increased if chickenpox occurs in the first trimester. If the pregnant woman develops varicella or shows serological conversion in the first 28 weeks of pregnancy, she has a small risk of fetal varicella syndrome and she should be informed to the implications. Can varicella infection to the fetus be diagnosed prenatally? Women who develop chickenpox in pregnancy should be referred to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after infection for discussion and detailed ultrasound examination. Given that amniocentesis has a strong negative predictive value but a poor positive predictive value in detecting fetal damage that cannot be detected by non-invasive methods, women who develop varicella infection during pregnancy should be counseled about the risks versus benefits of amniocentesis to detect varicella DNA by polymerase chain reaction. Amniocentesis should not be performed before the skin lesions have completely healed. What are the neonatal risks of varicella infection in pregnancy, and can they be prevented or ameliorated? If maternal infection occurs in the last 4 weeks of a woman's pregnancy, there is a significant risk of varicella infection of the newborn. A planned delivery should normally be avoided for at least 7 days after the onset of the maternal rash to allow for the passive transfer of antibodies from mother to child, provided that continuing the pregnancy does not pose any additional risks to the mother or baby. A neonatologist should be informed of the birth of all babies born to women who have developed chickenpox at any gestation during pregnancy. Women with chickenpox should breastfeed if they wish to and are well enough to do so. Thanks for watching. If you like my video, please subscribe to my channel and click the bell icon for more updates.